Hi, my name is Andrea Klein-Tilford. I'm a pediatric nurse practitioner, the immediate past president of the National Association of Pediatric Nurse Practitioners, and nurse practitioner director at the University of Michigan Health System. Welcome to this RSV microlearning session. RSV, when it results in hospitalization. Did you know nearly all children are infected with RSV at least once by the time they are 2 years old? For most infants and children, RSV will result in a mild illness. However, in some children, it can lead to serious illness and, in rare cases, death. There is not a specific therapy or a cure for RSV. Treatment relies on supporting the infant or child for the duration of the illness. Typically, this includes supporting breathing, clearing secretions, and maintaining hydration and nutrition. The supportive therapies can look different for each infant and child due to the severity of illness. To support the infant or child's breathing, there's a few forms of support that can be used. RSV results in lots of secretions, and facilitating their removal is essential. A bulb suction or a suctioning device attached to a machine can be used to clear secretions from the nose. Oxygen is commonly required when children are admitted with RSV disease. It can be delivered through nasal prongs, a face mask, or through other advanced respiratory supportive devices. When oxygen is indicated, the child will also be placed on a pulse oximeter and sometimes other advanced monitors. The pulse oximeter is a critical tool to measure oxygen levels in the blood and help guide oxygen therapy. When a child needs oxygen and is also experiencing labored breathing, more support than standard oxygen may be indicated. One option is high-flow nasal cannula. This setup looks very similar to standard oxygen, though is mixed with more humidity, and the oxygen mixture is described in a percent. Room air is 21%, and the highest amount of oxygen is 100%, along with a liter flow. This is different than standard nasal cannula that is delivered in liters per minute. With a higher amount of humidity in high-flow nasal cannula, the flow can be delivered at a higher rate without causing drying of the nasal passages. When the child is improving, the amount of flow will be weaned until the child is no longer needing the high-flow nasal cannula. Sometimes the child is transitioned to a standard nasal cannula before coming off of oxygen completely. Another option for respiratory support is a device called non-invasive positive pressure ventilation, or NIPPV. This method of support requires the use of a more fitted nasal prong or a mask that goes over the nose or over the nose and mouth. Additional evaluation of the skin integrity under the mask periodically and to monitor for signs of skin irritation or breakdown is also necessary when using NIPPV. When standard oxygen or non-invasive support are not successful, or if an infant has periods of apnea, invasive ventilation may be needed. This requires a breathing tube to be placed through the vocal cords, also called intubation. The ventilator allows more support than the non-invasive strategies. With the breathing tube in place, the child can still cry, though no sounds will be heard due to the tube that is placed through the vocal cords. The breathing tube requires suctioning to facilitate secretion removal from the child's airway and lungs. This is a critical piece of the child's care. Suctioning the breathing tube commonly causes a child to cough. This coughing helps bring up the secretions so they can then be suctioned out and helps to keep the respiratory muscles strong. As long as the breathing tube is in place, the child cannot eat by mouth, requiring placement of an enteral feeding tube to deliver food and nutrients. Sedation is often needed through an intravenous catheter to help keep the child calm while the ventilator is doing its job to allow time for the lungs to heal. There's not a set amount of time that a child with RSV will require the ventilator. If the child is requiring sedation while on the ventilator, the weaning phase will require that the child is more awake so that they can show that they are ready to take over the work of breathing. Sometimes it can be difficult to predict with certainty if the child is ready for the breathing tube to come out and for the child to take over the work on their own. A small percentage of children will need the breathing tube reinserted with another attempt at removing the breathing tube in the upcoming days. Oftentimes, RSV requires patience. It runs its course on its own time rather than on the time of the child, the family, or the healthcare team. There is not a way to predict if recovery will take days or in some cases weeks. Therapy in the hospital is supportive care while the child recovers from the illness, though there are not therapies to hasten improvement in symptoms or recovery. A few takeaways from today. Virtually all children are infected with RSV by the time they are 2 years of age. Supportive care, including oxygen, fluid, nutrition, and monitoring, is the mainstay of therapy. RSV runs its course on its own time, and each child recovers at their own pace. Thanks for joining.